Hi guys, we're going to go ahead and get started. Humor me, you can actually talk amongst yourselves for a second, but I am going to read the disclosure, so bear with me for a minute as I do it. You've all heard it about 3 times already. The bios, though, are interesting.
I move to make a motion to read the disclosures.
No, I have one job. I have one job here. It's to read it. Good afternoon, and welcome to Compliance Program Excellence, Keeping Abreast of Evolving Expectations, presented jointly by the Alliance for Home Health Quality and Innovation and the Visiting Nurse Associations of America. This session is being recorded. This continuing nursing education activity has been approved for 1 contact hour by the Maryland Nurses Association and accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. In order to receive your certificate of completion, you will need to attend this program in its entirety and complete the evaluation available in the conference app. Certificates of completion are available at the registration desk. Our faculty has disclosed no conflict of interest. A copy of the full disclosure sheet is available on the table outside the room. I'd now like to introduce today's presenters. Holly Chaffee has been leading Porchlight VNA's home care as president and chief executive officer since 2009. Porchlight has successfully gone through an organizational restructuring, branding, and merger. Porchlight is a 5-star home care elite agency serving 3 counties in western Massachusetts. Holly has guided Porchlight into a new era with the use of multiple technologies to make operations more efficient and data easier to collect and access. The continual implementation of new programs and use of multiple technologies has allowed Porchlight to evolve and grow in the ever-changing healthcare world. Under Holly's leadership, Porchlight and its exceptional staff is recognized as a 5-star agency that has achieved home care elite status, deficiency-free state surveys, and home care accreditation through the Home Care Alliance. Holly has held key leadership roles for more than 30 years in post-acute services, including certified and private pay home care, adult daycare, acute care, and assisted living in both for-profit and not-for-profit organizations. She has spoken nationally on home care, technology, and 5-star status tips, and innovative programs such as nurse practitioner and live-in caregiver. Holly has given presentations at the Remington Conference, the Northeast Leadership Conference, Decision Health, and the Visiting Nurses Association of New England, and the Visiting Nurses Associations of America, the Worcester Polytech Institute, and more. Holly serves as president of the board of directors for the Home Care Alliance of Massachusetts and the Lee Chamber of Commerce. Debbie Plesich is Corridor's Director of Operational and Regulatory Consulting Services and serves as Corridor's Compliance Officer. She is responsible for internal compliance oversight, operational and regulatory consulting offerings, and coordinator of client audits, compliance, surveys, OASIS, billing review, etc. Prior to joining Corridor, she served as Vice President of Clinical Operations and Compliance Officer for a large multi-state home health and hospice agency with locations throughout Southern California, Arizona, and Texas. During her more than 20 years of home health and hospice experience, she has been responsible for opening several home health and hospice startups and mergers, as well as preparing for accreditation and state surveys. Ms. Plesich's background also includes administrator in a home infusion pharmacy, as well as regional quality assurance manager for a national home medical equipment company. And with that, I'll turn it over to Holly and Debbie.
Well, as she said, I am Debbie Plesich. We wanted to ask the audience, how many of you are on board of directors for home health agencies? Okay, how many of you probably work for a big hospital system? Okay, so your corporate compliance issues are way different than home health agencies and hospice independently owned and operated agencies, for-profit, not-for-profit. The hospital agencies probably have huge corporate compliance programs, lawyers, consultants, all sorts of people that help them out. However, the rules and regulations are the same for both entities, and strongly recommend that even of those in hospital systems, develop your own corporate compliance program within your own home health agency. I presently work for the, where's the button? There we go. There we go. I presently work for the Corridor Group. We are a business partner for post-acute providers. And I provide consulting to agencies, get them ready for regulatory compliance, do surveys, and my background, like a lot of you, is very extensive in the home health and hospice industries. I fell into the compliance role because nobody else would do it. More than 20 years ago, compliance didn't exist, and it was always the QA department that had to do the audits, were the visits homebound, were the visits made before you send the bill out. That was years and years ago. And then OIG came into place, DOJ, with all of their recommendations to start a corporate compliance program, and Debbie, you can do it. And that's how it got started. The specialty of compliance has been around now for 20 years, which sounds like a long time, but it's really very short in the role of specialties. And it's now a huge certified special program. And it's so interesting when I meet with these people, many of us are clinicians, many of them are now lawyers, and boy, lawyers have a whole different take on a whole lot of different things. So a little bit more about CORDA. We do, I'm sure many of you know, revenue management, coding, advisory and compliance, and operation and education. And now a little bit for Holly.
So they told you a little bit about me and my background, and just a little bit about Porchlight. We have a full continuum of care from acute to chronic care. So that means we have the private pay company, we have the home visiting nurse practitioner, we have all the support services as far as living caregivers, home health aides, PCAs, homemakers, companions, drivers. And then on the certified side, your typical VNA services such as, the therapy, social work, nursing, and the complete continuum. So that's a bit about Porchlight. And we have our learning objectives for today. So we have we would like to be able to articulate the recent steps in the evolution of the OIG guidance on the effective compliance programs. We delineate different approaches to assessing the level of comprehensiveness and effectiveness of the compliance programs. And we want to outline for you steps to move to a more advanced level of compliance program comprehensiveness and effectiveness. And then what we're going to do is give you some practical examples of how you can apply this to your own individual agency board of directors.
Some of the recent changes with OIG, Office of Inspector Generals, is they're now really focusing on education and risk assessment. They expect the boards to be educated, and they want proof of that. And risk assessment is something else they're doing, so we'll be talking about that. A little cartoon here. Sorry, this is, at the end of the day, it's 4:15. You all want to be at the bar. We're going to save you your reputation for a little while. So Dilbert, in case you can't read it, did you have a chance to review my PowerPoint presentation? It's full of technical jargon, and it's way too long. Did you even look at it? Well, why would I look at something like that? So that's kind of the realm of corporate compliance, but we have a little game, not a game, but a technique for you all to try. There's blank pieces of paper. If everybody takes one, I promise it's not a test. Everybody take one piece of paper. Okay, now don't look at your neighbors. This is the important part. Don't look at your neighbor.
So
Just-
turn your chair around and
Oh, she's gonna make you do
follow our
more.
directions.
Okay,
Turn your chair around so you can't see the people that are sitting with you.
okay. Fold your paper in half.
Keep going.
Now fold it in thirds. Okay? Tear off the upper right corner. Don't look at anybody else. Tear off the lower left corner. Okay, now open up your pieces of paper. Here, have one. And turn around and share with your neighbors. You all had the same directions? Do you all have the same piece of paper? I can see not. So, again, you all heard the same thing, you all did the same thing, and we all have different outcomes. Today's been a lot of focus on outcomes. So again, OIG has a lot of guidelines, and they're up for a lot of interpretation. Lawyers interpret things very differently than a clinician, than the board of directors, than the administrator. Everybody can interpret findings much differently. So what is a corporate compliance program? It should contain the 7 elements developed by the Office of Inspector General, OIG. There should be evidence of compliance with the COPs, conditions of participation. We have compliance with accrediting bodies, Joint Commission, AHC. Most important, it should be a value-based corporate culture. You'll hear over and over again in the compliance world, value, it all starts and ends with the tone at the top. So what are the OIG 7 elements? They have stated that all of these elements contribute and should be a part of a corporate compliance program. In August of 1998, the OIG developed and published their guidelines in the Federal Register for a home health corporate compliance program. In October of 1999, they published guidelines for hospice agencies. They felt that this program should promote a higher level of ethical and lawful conduct throughout the entire health community. So these elements are written policies and procedures and written standards of conduct. Many of you probably have standards of conduct and you all signed them when you became employed. If you were employed more than 20 years ago, you better make sure you had done that because this didn't exist then. Seriously, you're all talking about being around for 20 and 30 years. Policies and procedures, we all have those, but you must make sure that you've got policies and procedures related to corporate compliance. You should have a policy that says you don't do anti-kickback, you don't pay for referrals. Those should be written out and defined in your policies. There should be a designated corporate compliance officer and a committee. The compliance program must conduct training and education for all levels. Again, you all got the training when you probably first started. There should be annual training and annual updates, and the OIG looks for this training. The more recent findings have been proof of education to your board of directors. They must be knowledgeable of what is a corporate compliance program and what is your corporate compliance program. It needs to develop effective lines of communication, and this can include a hotline and protection for whistleblowers. Enforce the standards, again, another policy. Conduct monitoring and auditing and conduct risk assessments. And the Corporate Compliance Committee must respond to offenses and develop a corrective action plan. You'll hear there's talk about an 8th element, and they're talking about annual risk assessments. Interesting to note, there's been several recent court cases, and they've cited organizations and actually used the data from the organization's risk assessment to cite them. The organization did a risk assessment, and they never analyzed it or developed a plan of action. They just had all this data that says, hey, we have laptops that could be stolen. Whoops, that's a risk. And that's where they left it. So we'll be focusing our presentation on board involvement and ensuring your program is just not on paper. That's where Holly's coming in.
Great.
So one of the tools that we've provided you is an audit component. So what's up on the screen here are some of the things that you would need to start to do or make sure that you have in place before you enter into your new compliance program. So the corporate compliance plan, the board of directors needs to vote on that. The designated corporate compliance officer, the board has to vote on that, as well as the corporate compliance committee. Also, you have to have job descriptions for these people and a personnel policy that's related to it. You have to have a hotline number and annual board education, your annual agency eval by your CEO, which was part of your PAC committee that you had to have that. And it needs to make sure that it's signed by the CEO of the organization. The current annual agency eval and the staff education has to be conducted, and you have to have the standards of conduct. All of these things that are listed, you have to have policies for. So it's kind of just a template tool for you guys to use. Feel free to take it and utilize it. An important part of it would be that the performance, that you perform initial assessment of your agency to your specific policies and processes for the compliance, and that you have a crosswalk between finance, operational, personnel, and QI, and that you prioritize the high-risk areas for your agency. I know for our agency, one of the things we're looking at now is texting. We know that we're fine with all other types of technology, that it's secure, but right now we're looking into the secure texting because some of the younger nurses really enjoy that feature, and we have to always constantly remind them, don't put patient information in texting. It's not protected yet in our organization. So I wanted to give you some examples of just common sense things that you want to make sure that you're doing in your organization that we make sure we do at Porchlight. So banking, for example, assuring that the person who's completing the deposits in your organization, like filling them all out, is not the person that's taking them to the bank. There's a reason for that. You want to make sure that, nothing's happening in between. You want to make sure that there's a check signing to be sure that the CFO and the finance people are not the only staff signing off on the checks, and that you review the list of checks that are being written, looking for missing check numbers. The reason for that is we actually had somebody have a check that looked like our organization check, had our routing number, had our banking number, and people signed off on it, but it wasn't our check. So that happened to us once. So obviously somebody got a hold of it, was able to create a check, and was able to cash it. So it's really important that you check those check numbers and review those bank statements as they come in. A couple of other ones would be to review payroll change logs. Pay attention, I don't know if in your organization, but we do have people in our organization that are related to each other. So for example, my CFO's daughter works for us in the scheduling capacity. So you want to make sure that you're checking on those things, that you're checking the earn time, that people are, using their sick time, and that it's not like being bypassed. The person that's inputting the accounts payable is not the person signing off on the checks, that the person preparing the bank deposits is not making the bank deposits, and that your annual financial audit presentations are not just to the board of directors, but that they're to your managers so that things are transparent. Clinically, you want to make sure that your quarterly chart reviews are utilizing the technology that you have available to you to assist with the process, and that those clinical audit findings are presented to your board of directors, and that and to your staff as well, so that they can see what your findings are. The more transparent you can be, the better off you're going to be. Accreditation audits. Our organization, our private pay company, is accredited by the Home Care Alliance in Massachusetts. So they have standards and guidelines. So it's always good to just, do those quarterly checks to make sure you're keeping up with all those standards, so that when the audit comes at the end of the year, you're in great shape and you don't have to worry about things. Respond promptly, as Debbie was saying before, to any detected offenses and report concerns that you identify, and bring them to your committee. The detected offenses are not going to go away. So like we identified that texting is an issue in our agency, so we can't ignore it. We have to do something about it. We had a situation where we had some contract therapy staff. And when we were doing our chart audit reviews, we learned that this contract therapist was just cutting and pasting her documentation from one patient to another. So the audit revealed that very quickly, and it was a contract staff, so it wasn't somebody that we had educated, and so we had to deal with that. Elder service billing, I don't know, in our state we have what we call the ASAPs, so the elder service federal funding that comes to us. And one of the things we learned through our billing is we use a telephony system. So our aides, when they go into the house, they check in by telephone, they check out by telephone, they do their care plan by telephone. So they're supposed to do that from the patient's phone because that's considered their electronic signature. Well, some of them were doing it from their own cell phone. So then that would require them to have to get a signature from the patient on paper. So we're trying to get rid of the paper. So we're constantly on a weekly basis re-educating aides and bringing them in to review that process with them. Because if you don't have the patient's signature and they're not calling out from their phone, you really can't validate that they've been there. Medication errors, make sure that you're reporting them to the doctor's offices. That will avoid some things. And then you have some self-policing ideas. If someone reports that they suspect someone is falsifying documentation, follow up on it. If they're saying, oh, so-and-so was in the parking lot during that time, she couldn't have been at the patient's house, make sure you're following up on anything that's reported because it's probably true. So you need to really look into those things. Bank statement discrepancies, I explained that situation that we had. Verifying signatures of clients and doctors on those attestation forms. We did have a situation where the office staff was signing off the physician's name and the physician wasn't reviewing those documents that he was supposed to be signing, the orders. It was someone in his staff. And so we looked at the signature and said, whoa, wait a minute, that's not the one. Had to call the office to find out what was going on. We had a couple of other situations. We had a PA up in one of the counties we serve in who was insistent that he could sign 485s and didn't need the physician to do that. And we gave him all kinds of documents. I think I have a folder on this guy like this thick, showing him why that wasn't allowed. And he continued to do it. Well, needless to say, he was reported and he no longer has a license because he just really insisted that the physician that his collaborating physician was actually nowhere in the country. He was out somewhere else, and that's why he had this arrangement with the doctor. And so it wasn't a good situation, but you have to report these things because these are the kinds of people in our realm of practice that are giving us a bad name out there. We also had a medical director who became the medical director of a large for-profit agency in our area. And he was being paid large sums of money to do presentations for that organization in exchange for him just giving this organization all of his referrals. So when one of my staff called up the doctor's office and said, well, this patient would like to have our organization. And the secretary there said, well, this doctor refers all their patients to this organization. So I'm sorry, but they can't come to you. So, I mean, it was that blatant. And needless to say, that doctor's no longer practicing either. I don't know how they all land in the county we serve, but they do. And then on the private side now, there is the issue of live-in caregivers and how they're paid. So you have to make sure that you're paying attention to what the rules are and how they change, and that, we used to pay a live-in caregiver a daily rate. We can no longer do that. We have to pay them hourly, and then we have to pay them overtime over 40 hours. So we've worked out that formula where we pay them minimum wage for the first 40 hours they work, and then we pay them time and a half after that. And they have to have 6 hours of uninterrupted sleep and a 2-hour break during the day. So you can discount that 8 hours as long as the patient is sleeping during the night. So those are the kinds of things that can get you into trouble if you're not paying attention to them. So here's Deb.
Okay, I'm back of screen. So what are the evolving changes and positions for the OIG and the DOJ? In May 2009, HEAT was created, Healthcare Fraud Prevention and Enforcement Action Team. Ooh. It is a multi-agency team. It consists of federal, state, and local investigators, and they focus on community policing. This HEAT team goes into communities. They've been focused in Florida for a while, but they're all over. And they will identify from within the community these agencies that they feel are committing fraud. In April of 2015, the OIG and the Department of Health and Human Services published the Practical Guidance for Healthcare Governing Boards on Compliance Oversight. All of you in compliance need this document. We have it attached. It's not very big. I mean, it's not a Federal Register, which is 300 pages and 2 font. It's actually really readable and a very, very useful tool. And it says what it is, practical guidance, so you all better be following everything it says. In September of 2015, Sally Quillian Yates wrote a memo regarding individual accountability for corporate wrongdoing. This is now called the Yates Memo, which you'll hear about, and it provides a new emphasis on holding corporate executives accountable for corporate wrongdoing. She advises the counselors, the attorney generals, the ADAs, to focus on individuals at the beginning of the civil and criminal investigations, and she recommends to resolve the individual cases prior to developing the corporate cases and pursue civil actions regardless of the individual's ability to pay. So anybody on the board of directors of an agency that's been fined for doing illegal fraudulent activities, they're being held accountable first. So this was a huge new and evolving change for them. By the way, Sally Quillian Yates has been fired, like all the attorney generals of Trump, but her memo continues. On November 3rd, the DOJ hired Hui Chen as a full-time compliance expert. He provides the whole government with his expertise in compliance. Okay, just this year, on January 4th, CMS held a special open door forum, Recent Resolutions and Enforcement Activities by Stephen Lee. He's an ADA, I think he was out of the Chicago office. I don't know if any of you were on that. I listened to this open door forum, and it made me sick. We've all heard about how our public persona is that we all commit fraud. You have to listen to what he said, and I am quoting. There was a 59% improper payment rate on home health claims in 2015. 59% improper payment rate. Where does he get this from? From ADR results, CERT results, pre-claim review findings, OIG findings of prior document submissions. In his presentation, he said, again I quote, "Nurses lie to make their patients seem sicker. Nurses state they have been told to document homebound status if they see a cane in the home. Nurses visit for 15 minutes and document teaching on conditions that the patients had for years. Nurses create fake documentation." Everything was focused on nurses. Then we went on to state that the face-to-faces do not actually occur. Okay, we've all been the victim of ADRs and probe and edits. Did the face-to-face not occur, or were the I's not dotted and the T's not crossed, so therefore the face-to-face didn't occur? I got off of it. I could only stay on this open door forum for a short time. I was with somebody else at the time, and it was awful. But his results, this is what he does every day, is prosecute these fraudulent agencies, so you can see why the federal government thinks we're all fraudulent. We must prove our innocence on a day-to-day basis. And this year, the OCR is conducting HIPAA audits. 2 years ago, they did them. They were called desk audits. They would send out a request. You had to send your stuff back. Now they're conducting field audits. And part of the OCR, Office of Civil Rights, inspection for HIPAA compliance is they're going into agencies, hospitals, et cetera, and not only looking for your HIPAA compliance, but inspecting your physical layout. Are the records locked up? Do you have a shredder? Let me see the shredding company's contract that you have, and it's got to be a BAA. So they're actually going into agencies to look for things. Oh, there you go.
So just to give you a couple of examples of potential HIPAA violations that we've come across. We were working with a rather aggressive consultant at one point that I had inherited when I came to my organization.
Not me.
And this consultant had a relationship with one of the board members. And, you know, we have an old organization. It's 105 years old. We had some board members who were on our board for many, many years. And some of them have loose lips. So when we let the consultant go and stop that relationship, this particular board member would continually go to him with the data from our organization. And we learned this through the grapevine and approached the board member and said, hey, you know, you really can't be doing this. What's happening in the board stays in the boardroom. And he continued to do it. So we had to make a bold move to remove this board member from our board. And he was, you know, one of the pillars in the community, but he just could not stop talking. So it was something that had to be done. You can't ignore these things. You can't say, well, you know, you just have to deal with it. You do have to complete your business associate agreements on an annual basis, so make sure you're doing that with all of the vendors you're utilizing with. We have a partnership with Corridor Group. We have a business associate agreement in place, those kinds of things. And your corporate compliance program must be put into place with your assigned corporate compliance officer.
So how many of us have been in a doctor's office? Mrs. Cranley, you need to sign this HIPAA privacy form before the doctor can look at those warts on your stomach. Yeah, we've been there. Okay, so what are some of the resources and guidelines? OIG, DOJ, HEAT, and OCR have published guidelines and training materials which will provide structural foundation to self-police conduct through effective compliance and ethics programs. These assessment tools can be used to meet the requirements for an effective compliance program. Some of the other things you'll see are what's called federal sentencing guidelines. You can Google that and you'll see all sorts of federal sentencing guidelines and see what people got fined for and what the sentencing was. The OIG has a voluntary compliance program guidance and something else called corporate integrity agreements, or CIAs. These are actually agreements that have been made between fraudulent organizations and the OIG, and it's their plan of correction. So when you read these corporate integrity agreements, you can see the interpretation of how the OIG is interpreting things. Now, a little bit about the practical guidance for healthcare governing boards on compliance oversight, which was published by the OIG in April of 2015. Right in the introduction, the guidance states that a critical element of effective oversight is the process of asking the right questions of management to determine the adequacy and effectiveness of the organization's compliance program. So it makes a compliance a responsibility for all levels of management, and an effective compliance program will evaluate the performance of key personnel involved in the development and execution of the program. The guidelines also state that you should focus on providing practical ideas for board consideration. Boards must ensure the adequacy and effectiveness of the organization's compliance program. And boards must evaluate the performance of key personnel involved in the development and execution of the program. Once again, the tone at the top. Did I go backwards? No, I'm good. Okay. Board meeting report context. I think this is Holly's. There you go.
So CEO report that I give to my board on a very regular basis is extremely transparent. And what I began to do shortly after I joined my organization 8 years ago was to get my managers involved in reporting as well. So we have the quality manager developing a report for the board, which includes the KPIs such as hospitalized patients, complaint resolution, incident reports, star ratings, HCAP reports. Those things were very important. Our financial reports, including reasons for budgetary compliance, being very transparent about what's happening on a very regular basis. The more they know, the more protected that you are as a CEO. Human resource reports included workers' comp cases, staff hired, staff that resigned, staff that was terminated, staffing challenges that were there, and the home care division reports, metric reports for the private pay company. So we really feel it's really important to educate all levels of your organization about compliance. It's everybody's job. So the board of directors, your executive management team, your clinical managers, your clinicians, and all of your field staff, everybody really needs to be involved in this. So your board agendas really should include your mission statement, conflicts of interest per meeting, have anybody disclose those, registered guests that are attending, make sure they're signing in, and have a conflict of interest statement signed annually by all your board members, and review the bylaws annually as well. So this, I'm not going to go through each step of this, but this is a compliance policy checklist that we gave to you so that you can check in your organizations to make sure that you have all of these things in place. It will really help you. It's like about 3 slides long. And then expectations of the board oversight of compliance program functions. So review the roles of and the relationships between the organization's audit, compliance, human resource, and legal departments. It's very important to do that. Ensure that your data is valid and accurate as it's tied to reimbursement. And you want to make sure that you're conducting regular executive session with leadership for the compliance, including your legal, internal audits, and your quality functions, and keep current with payment models through sources such as the Pepper Report. So an example of a potential risk, we had a merger about 3 years ago. The day before the merger, we did due diligence, we had attorneys, we did everything. And the reason we had a merger as opposed to an acquisition was because the boards really felt that it was important to do it that way. So the day before the merger was in place, the agency we were merging with had a RAC audit. So we weren't prepared for that. We weren't expecting that. It ended up turning out okay in the end, but those are the kinds of risks that you need to make sure that you're looking out for if you're going through mergers and acquisitions. The OIG, is that you? The OIG warns boards that they must be fully engaged. Fiduciary responsibilities and obligations must be taken seriously. They need to understand how responsible they are when they sign on as your board of directors. That, you know, individually they can be sued. That's why you have insurance policies, but they need to understand how serious the obligation is. Learn how quality and patient safety and compliance information flows to the board. Educate the board on the structure of your compliance program and the organization, fraud, and abuse risk areas. So what Porchlight did was we actually hired an attorney to be our compliance officer. And then our executive team is the compliance committee. And the compliance officer will take care of doing the training on all levels. And we feel really comfortable with that because it's transparent. She will monitor the hotline, and she'll bring forward to the committee any concerns that come up. Ensure that your reporting systems bring the appropriate information relating to compliance and the applicable laws in a timely fashion. And if a business is lagging, invite managers to discuss their strategies for improvement. That's really important. And perform regular self-assessments of your board and its committees. So this is a sample annual board resolution, which says, I approve of the establishment of a formal compliance plan for Porchlight B&A and Home Care, and I further approve the appointment of the compliance officer. And it has to be signed and dated by each of the board members. All information at a board meeting is confidential, and I believe I already talked to you about the board member that we had that was having some problems.
Yeah. So how do boards stay on top of compliance? Board members should, but your committee can also help them by following cases involved in the industry. Review the corporate integrity agreements, like I mentioned before, resulting from court cases. They might want to take advantage of outside educational programs, and if they do, they should document it, turn it in, so you all have evidence that they've contributed to an outside educational program. The board may want a formal education calendar to be posted so that they can be updated on it. How to assist the boards in identifying quality report to the board would include clients not taken and why. I was just at a conference before and we talked about, I called them NTUCs, not taken under care. Other people call them NTUs, not taken up. But that's an important, why didn't you take this patient under care? We're not just talking about marketing or a loss of revenue, but there could be some fraud. Why didn't you take all the Medicaid patients or Office of Civil Rights? Why didn't you take all the patients in XYZ zip code for whatever reason? You want to show the patient hospitalization rates for your agency in comparison to others, and the need for technology to be compliant with board demonstrations. So some of the potential high-risk areas that we've all known and loved about, they're referral relationships. I have a story about an investigation that went a completely different way than what I was involved with. There was a community liaison that was let go for poor performance. She was very angry and accused another liaison of paying for referrals and giving expensive gifts and other things that were illegal. And so this person that was let go was angry and talked to everybody about it. The management team who heard the accusations just dismissed her as disgruntled. Office staff as well as field staff all also heard her angry comments but said nothing. The HR department expressed concern to the management team, but again, the accusations were dismissed as a disgruntled employee. This spun around the office cooler. When the HR director heard the comments or the gossip, she expressed more concern and brought it to upper management. Well, upper management was afraid she was going to go to the DHS office, so they brought it to the attention of the corporate compliance officer, and the corporate compliance officer informed the board and conducted an investigation. The investigation went to root cause and was very detailed. It included interviews with the disgruntled liaison, all staff members, whether they heard her directly or indirectly, and then the corporate officer conducted on-site field interviews with referral sources. There was also a form that was created and given out to all the community liaisons, which they had to complete and sign. Do you know of anybody that's paid for referrals? Have you ever paid for referral? It was worded that way, and they had to sign it. The results of the investigation was communicated to all staff members in a staff meeting and directly with the disgruntled liaison. The disgruntled liaison expressed appreciation that she was listened to, so right away calmed her down. She didn't fully believe the results, but agreed there was nothing more she could do, and was very appreciative that a field survey had also been conducted. Of course, the office staff and the field staff were feeling very good that they were working for a really good agency that was very ethical. But there was another interesting finding that occurred. When they reviewed the forms that the community liaisons turned in, another liaison admitted to giving gifts. When they interviewed her, she said, well, it wasn't money and it wasn't expensive. I know the agency can't do it, but these are people that were my friends. I've worked with them. I wanted to show them my appreciation that they thought of me when they had a patient that needed help. This liaison did not come up on any reports. She was not outstanding. She didn't have a lot of referrals, so nobody in the other agencies even knew this was going on. Needless to say, the investigation increased in scope, and the agency now does that form every year by every liaison, and they do that investigation. But it's important, if the board hadn't gotten involved, if somebody hadn't thought of something else to think about, the investigation might never have happened. So it's very interesting and helpful to get everybody more involved. Billing problems are another areas of risk. We all know about upcoding and submission of claims for services not rendered and not medically necessary, extended lengths of stay in hospice or frequent discharges and readmissions. The board and all of us, all of you, must consider the human element. Are the RNs in your agency, we all talked about scoreboards today and dashboards. So if your RNs are being held accountable because they don't show improvement, what is their incentive to start downcoding, upcoding, so they don't get yelled at every other week when their reports come out? I mean, we have to think about how that's going to be translated to your staff members. Are managers required to submit monthly reports? Maybe there's some pharmacy reports and you want to show cost containment for pharmacy. At the same time, it's turning into a pain assessment. Well, the managers want to get their bonuses, and they better have good pain assessments, so all of a sudden the reports start getting a little hygiened. Are patients being discharged with readmits so that you don't have extended length of stays on your PEPA reports? These are all these different things that you have to think about, what these illegal people do that we would never think about. Sometimes what I find in hospice agencies is RNs are recertifying patients. And why are they being recertified? Because they don't have anybody else to take care of them. If we didn't come, if the aide didn't come, there's no family members around. I can't discharge them because then she will really die. Well, there you go. These are examples of some nickel-dime dollars, but examples of true risk analysis management investigations. So new industry trends require risk analysis, value-based purchasing, bundled services, and global payments to maintain and improve health are just a few. Some of these payment models have incentivized consolidation and contractual relationships. These trends lead to new incentives. Now, interesting, the government has created some safe harbors with some of these consolidations and contracts, but you have to look very carefully to see if you are involved in a safe harbor that could be saving you. What are the top auditing problems that OIG has stated? No risk assessment is conducted. Maybe you didn't and didn't write it down. No analysis of the risks, like we mentioned before. Sometimes there's too many audits and no prioritization of those audits. You have all this data, what are you going to do with it? Discounting the data. Well, I live in a zip code that they're very poor, and that's why my data is so bad. They just discount it. Reports and data is not submitted to the board, and data collection is irrelevant. You're collecting data for no apparent reason. Oh, I did your slide, Holly.
Good. Okay, keep going.
Examples of solutions is utilize technology. We've been hearing about that all day today. Use SHP or similar, HH Gold, I heard of another one, to scrub. That will also help identify risks. Utilize the reports. We did a big thing just a little while ago on reports that are available. Be transparent with your board and report all the audits to the board of directors. Let them help you interpret these guidelines because they'll have a different question that we all didn't think about. So I think, where are we? We're a little early. Anybody have any questions? Any other examples of horrible, scary things that almost happened and didn't, or you heard they happened? Okay, well, we're done. Thank you all for attending, and I really appreciate that you all attended because corporate compliance can be really boring and there's a lot more interesting things down the hall, so thank you for that.